Welcome to Compassion and Choices Staying Stronger Together webinar series. Today we'll be looking at medical aid in dying across the states, a compassionate end-of-life care option. This webinar is part one of a two-part series where we'll be examining medical aid in dying across the nation. Today's speakers are Kim Callanan, Compassion and Choices President and Chief Executive Officer, Sylvia Trujillo, our Policy Director and Senior Legislative Counsel, and myself, I am Corinne Carey, and I'm a Senior Campaign Director with Compassion and Choices. This is a re-recording of a webinar that we held on March 14th. And since we had a number of technical difficulties during that webinar, we decided to re-record this. We're going to be going over the same great content and clarifying a few things based on the feedback that we received from participants. We've also included responses to live surveys that we did during that webinar, and we'll respond to the original questions that were asked during the webinar. In fact, our hope is that we'll be able to get through more of those questions than we were originally able to do. So let's get started. What will we cover on this webinar? First, we'll take a look at a national overview of our movement to expand end-of-life options across the country. Next, we'll dig into medical aid in dying laws and the data that we've seen coming out of states that have authorized this option. Then we'll take a look at how states that haven't yet authorized medical aid in dying can do so and do so quickly. And finally, we'll take questions and provide answers to some of the most commonly asked questions about these issues. First, we asked our participants on the webinar, how familiar are you with medical aid in dying? We asked, are you very familiar, somewhat familiar, or not at all familiar? And here were the answers to the poll. 42% of our participants were very familiar with medical aid in dying, 53% were somewhat familiar, 5% were not at all familiar. So we had a great mix of people attending the call. Let's all get on the same page about what we're talking about before we begin. Medical aid in dying is a medical practice that provides a terminally ill, mentally capable adult with a prognosis of 6 months or less to live, with the option to request a doctor's prescription for medication that they can decide to self-ingest to peacefully end unbearable suffering. So as you hear us talk about medical aid in dying through this webinar, this is the practice that we're referring to. I'm going to turn it over to Kim Callanan to give you an overview from across the country on our medical aid in dying movement.
Thank you so much, Corinne. It is an honor to be here today and to have a chance to talk to you about medical aid in dying. Next. So I'm going to start with 2014. This was the year that a beautiful young woman named Brittany Maynard came forward and shared her story. She and her husband, Dan Diaz, partnered with Compassion and Choices. She lived in California at the time, and unfortunately, California did not yet have a medical aid in dying law. She was dying from a terminal brain cancer and moved from California to Oregon in order to access their Death with Dignity law. And this is what sparked the current momentum towards the passage of medical aid in dying across the country. You'll see from this slide that the movement started first here in the United States in 1994 with a ballot initiative in Oregon. And then 10 years later, or even longer than that, you had in 1997, the Oregon law was finally implemented, and then it wasn't until 2008 that Washington State had a ballot initiative. things kind of slowly progressed, and you can see from the 2015 was 1 year after Brittany came forward and shared her story that we were able to pass the legislation in California. And since that time, we have seen unprecedented progress with authorizing 6 more states in 5 years. Following California, there was a ballot initiative in Colorado. Then you went through the legislature in DC, Hawaii, New Jersey, and Maine. We now have 1 in 5 adults that have access to medical aid in dying and live in an authorized state. You can see in 2020, pre-COVID-19, there was legislation to advance medical aid in dying in 20 states. And there were several states that had legislation that was advancing to reduce regulatory roadblocks and improve the existing model medical aid in dying legislation. Part of the success of this movement is the widespread public support that we see. It does not matter what survey you look at, roughly 7 out of 10 Americans support the option of medical aid in dying and would like to have that option for a peaceful end. We also know that demographic support is high among all demographic groups, regardless of whether you're talking about race or religion, party identification. The large majority support and want medical aid in dying, and you can see from this slide, in some cases it's overwhelming support, like 84% of non-religious, and in some cases it's majority support. But across the board, people are supportive of this compassionate option. This is also true among people with disabilities. If you look, we did surveys in New Jersey, Connecticut, and Massachusetts several years ago, and you see that between 63% and 74% of people who have disabilities want the option of medical aid in dying for themselves. Unfortunately, while people with disabilities want this option, there are some leading disability groups that are opposed to medical aid in dying. In recent years, though, we are seeing that the widespread public support that we're seeing around medical aid in dying, you're having more organizations adopt neutral or supportive policies, including leading disability groups, especially at the state level. So Disability Rights Oregon has regularly issued a letter letting everybody know that in the state of Oregon, there has not been a single incidence of abuse or coercion or person with a disability who's come forward asking them or suggesting that there's been abuse or coercion. And in the past couple of years, in New Mexico and in New York, we have seen local disability groups adopt supportive policies or dropped their opposition, with 3 of them noted here on the slide. We recognized a couple of years ago that it was critical for this movement's continued progress that we prioritize the diversification of the movement, and we formed our African American and Latino leadership councils to help us guide those efforts. In forming those efforts, one of the things that became abundantly clear to us was that it was important that we were helping to close the disparities in end-of-life care that exist for communities of color around advanced care planning, hospice care, palliative care, and pain management. And we have seen among Latino organizations, 6 national Latino organizations and state-based organizations adopt supportive policy. As an example, the National Hispanic Council on Aging, as well as the Dolores Huerta Foundation and others that are noted here on the slide. Among the African American community, we are also seeing growing support. It started with Washington, D.C. as the first city that is majority Black adopted a supportive or passed medical aid in dying legislation. We were able to garner the support of all but 1 African American city council members and also the mayor. We also saw support from Congressman Anthony Brown, the late Congressman Elijah Cummings, and who's known as America's psychologist, Dr. Jeff Gardier, has come forward and endorsed the option of medical aid in dying. And there are a host of other well-known figures that have lent their support and voice to our cause, from Mauricio Ochman to Stephen Hawking to Diane Rehm. We also recently have Anna Camp has also come out in support of this option, and she is in a new movie, Here a While, that will be coming out on June 9th, I believe. Among the medical profession, we also see individual doctors themselves support the option of medical aid in dying, and that support has been on the rise. You can see back in 2010, 46% of doctors supported the option, and now 58% support. And this is a survey that was done independently by Medscape. As a result of the growing public support, as well as the increased support among doctors, you're seeing a growing number of public and professional medical associations adopt supportive policies or drop their opposition. In fact, since 2015, when Brittany Maynard first came forward and shared her story, 21 medical societies have dropped their opposition to medical aid in dying. You can see from this slide how some of the national medical organizations stand on this now. We're seeing increased support. In the middle, you have the American Academy of Family Physicians, and they came forward with a position of engaged neutrality. Engaged neutrality was first spoke about in November of 2016 in an article that came out in the Annals of Internal Medicine by John Fry and Stuart Younger, and they basically argued that this idea of staying neutral was not actually in the best interest of doctors, because once a state has adopted a supportive policy and it is now a legal medical practices, professional societies owe it to their doctors to help them to be able to understand how to properly care for patients who want this option. We've also seen some movement among the American Medical Association. They adopted last year a new policy position that was recommended by their Council on Ethical and Judicial Affairs around medical aid in dying. The new policy was a disappointment in some ways. For example, they continue to very pejoratively refer to medical aid in dying as a physician-assisted suicide. However, in other ways, it was a step in the right direction, because it was the very first time that the American Medical Association affirmed that physicians may in fact participate in medical aid in dying without violating their professional obligations. So while it was not the position that we entirely hoped for, it was absolutely a step in the right direction, and it reflects the fact that the AMA now recognizes the growing support among both doctors and their clients for this end-of-life care option. We're also seeing leading national organizations who address the issue of suicide rejecting the comparison between medical aid in dying and suicide. Both the American Psychological Association and the American Association of Suicidology have found that suicide and medical aid in dying are fundamentally distinct from each other. And we are seeing increased momentum across the country because the evidence is both extensive and conclusive. We now have nearly 50 combined experience across 10 authorized jurisdictions that demonstrates that medical aid in dying is a proven medical practice, with 1 in 5 Americans having access to this option. And it is this evidence and this data that allows us to continue to make progress across the country.
So thank you so much, Kim, for that fantastic overview. We asked participants in this webinar another question. We asked them to tell us whether medical aid in dying is authorized where they live. And the answers that we got were that 32% of our webinar participants live in a jurisdiction where medical aid in dying is authorized. 63% did not, and 5% were unsure. We are going to move now to an overview of what these medical aid in dying laws look like. And for that, I'm going to turn the presentation over to Sylvia Trujillo. Sylvia?
Thank you, Corinne. Could you proceed to the next slide? Thank you. At Compassionate Choices, we are advocating for legislation fundamentally that explicitly authorizes terminally ill, mentally capable adults with a prognosis of 6 months or less to request, receive, and if they choose, self-ingest medication to bring about a peaceful death. These laws should align with and do with widely accepted clinical practice guidelines and create a responsible, compassionate medical practice accessible to patients while providing appropriate protections for them and their providers. Next slide, please. Most of the laws in the authorized states are modeled after the Oregon Death with Dignity Act. All contain the same strict eligibility criteria. The individual must be a resident of the state, aged 18 or older, terminally ill with a prognosis of 6 months or less to live, mentally capable of making healthcare decisions, acting voluntarily, and they are able to self-ingest the medication. It's important to note that no individual is eligible based on advanced age or disability. Next. Medical aid in dying is optional for everyone, both patients and providers. This is an intensely personal decision that individuals must make for themselves. Those who have differing opinions are not required to participate. For those who do, they are extended criminal and civil immunity as long as they comply with all aspects of the law. Additional protections extend to terminally ill individuals. These laws include explicit penalties for anyone who attempts to pressure, coerce, or exert undue influence on an individual to request, obtain, or utilize medical aid in dying. Likewise, acts of negligence and intentional misconduct are not covered under the immunities. Next. In all jurisdictions, including Montana, where clinicians follow the eligibility and common regulatory requirements from other jurisdictions, we know from a combined 50 years of experience that the current medical aid in dying laws are unnecessarily onerous. We are asking a dying person to go through essentially a 13-step process in most jurisdictions, and too many individuals are suffering and not making their way through the process. We know that all of the steps are not necessary to protect patients, but we of course absolutely need core safeguards. Our goal now is to make sure that we remove the provisions that are unnecessary while ensuring that the core eligibility criteria and safeguards remain in place. Next. This is an overview of some of the differences in a number of jurisdictions that are impediments to access. And while each state is responsible for the regulation of medical practice, and differences may reflect different community standards and realities, it has become very evident that in the jurisdictions where medical aid in dying is explicitly authorized, these differences are driving impediments to access. For example, in the state of Hawaii, their most recent annual report noted that their 20-day waiting period as compared to the 15 days that is typical in most other jurisdictions is too long, and it is a significant barrier. It is not the only barrier. You see here a number of others, such as a 48-hour patient pre-death attestation that is required in California and Hawaii. Next slide. In 2019, Oregon, in light of these impediments, passed an amendment permitting waiver of the applicable waiting period in that jurisdiction for individuals unlikely to survive a 15-day waiting period. This highlights the need to address requirements in other jurisdictions that limit access and unnecessarily. Next slide. In 2020, two states with authorized medical aid in dying laws have bills that have been introduced to address some of the roadblocks to access. In Hawaii, legislation was actively considered that would authorize advanced practice registered nurses to support medical aid in dying requests. They would reduce the waiting period from 20 to 15 days. They would waive the waiting period for individuals not expected to survive the waiting period, and also authorize psychiatric mental health nurse practitioners. In the state of Washington, legislation was also considered that would have required all providers to provide public notice of their policies concerning medical aid in dying and make that publicly accessible, as well as fund a bill to identify what are additional impediments and barriers to access. Next slide, please. Now we're going to cover some of the data that we have to really fully understand what medical aid in dying looks like in practice. Next slide. Currently, 7 states and DC have issued reports regarding the utilization of medical aid in dying laws. The data demonstrate that the majority of individuals who request medical aid in dying are 65 years of age or older, with a median age in the mid-70s. There's nearly equal utilization between men and women, and they are predominantly white, insured, and well-educated. Terminal cancer accounts for the vast majority of qualifying diagnoses, with neurodegenerative diseases such as ALS or Huntington's disease following as a second leading diagnosis. Most are receiving concurrent hospice or palliative care at the time of their deaths. Next slide, please. The top reasons provided by eligible individuals include loss of autonomy, dignity, diminished quality of life, and fear of pain and suffering. But the documented experience tells us that it is not really any one reason. Rather, it is the totality of what happens to one's body at the very end of life. The strict eligibility criteria and the core safeguards are the primary reason the Journal of Medical Ethics concluded that there is no evidence of heightened risk for the elderly, women, the uninsured, people with low educational status, the poor, the physically disabled or chronically ill, or people with psychiatric illnesses, including depression or racial or ethnic minorities. Next slide, please. Based on the data from these jurisdictions that have been published, less than 1% of people who die annually in an authorized jurisdiction will decide to use the law, but large numbers will benefit from simply knowing the law exists. In fact, rather than posing any risk, the availability of this option has been linked to significant improvements in the end-of-life care for all. Doctors report that since the laws were implemented, they have made a point of improving their knowledge of pain management, hospice, and other end-of-life treatments. This has improved the conversations between doctors and their patients, and this in turn has resulted in greater patient-centered and patient-directed decisions at the end of life. Next slide. So to recap really quickly, we have nearly 50 years of combined practice across the currently authorized jurisdictions. There's never been a single substantiated claim of coercion, abuse, or misuse, not once. That is because the law's core requirements were intended to ensure individuals are able to peacefully end intolerable suffering without creating unnecessary risks for patients or providers. Simply knowing the option is available provides comfort and peace of mind to dying individuals, allowing them to live their remaining days to the fullest, even if they ultimately choose not to request or to self-administer the medication. And with that, I'd like to thank you and turn this back over to Corinne.
Thank you so much, Sylvia. Let's turn our attention to how we pass legislation that authorizes medical aid in dying. Compassionate Choices has decades of experience in working across the country to pass these laws. And what we've learned is that it really takes 3 different pillars. First, we need to be vigilant and recognize that language matters. We need to use research-based messaging when we're talking about authorizing medical aid in dying. The next thing we need to do is prepare. It's not enough to just have the poll numbers be in the right place and show that the majority of voters in a state believe in medical aid in dying. We also have to prepare for legislative campaigns by building the public demand, and that requires grassroots organizing, doing outreach through traditional and social media, and finding and supporting people who are willing to share their stories about why medical aid in dying is so important. We also need to neutralize opposition. Sometimes that comes from medical societies or other constituent groups. We need to work to change that opposition to neutrality or support. We also have to educate state lawmakers and recruit strong bill sponsors and co-sponsors in both the upper and lower houses of each of the state that wants to pass a bill. Securing the public endorsement and the leadership of the executive, making sure that the governor will sign a bill that makes it to his or her desk is a really important part of preparing for the legislative campaign. And then finally, supporting CNC's fundraising efforts is really critical, and I can't emphasize this enough. We need the funds to be able to do all of that grassroots organizing. We also have to support what we call near next states, or states that are likely to pass a bill sooner than maybe yours, because that helps our national effort. When we passed the bill in New Jersey, that definitely gave a boost to our New York, our Massachusetts, and our Maryland campaigns. We also want to make sure that we're supporting national tide initiatives, things that will move our movement forward, and also engage in advocacy that protects the movement. Every time we pass a bill, the opponents are determined to either overturn it in the courts or roll it back in the legislature, and funding our efforts to defend those laws is a really important part of moving this movement forward. We use a blended approach to passing legislation that is synergistic and cost-effective. We take our national resources, our tools, our people, our approach, and our infrastructure, and we add that to local organizing that already exists on the ground, or local organizing that we help to support. And that helps us achieve the fastest, most cost-effective route to authorization. What does CNC bring to the table? We bring millions of dollars in proven, tested, research-based messaging. We constantly update our database of opposition claims, and we counter those claims with research-based truths. If you have heard an argument against medical aid in dying, we've heard them all, and we've developed messaging to counter them. We've also developed model legislation based on lessons we've learned in other states. Time-tested fact sheets and materials for lawmakers, constituents, and the general public, and how-to guides to build every necessary component of a successful legislative campaign, from action teams to supporting storytellers to increasing diversity among your supporters and recruiting lawmakers. We also have training programs designed and delivered by staff who have run winning campaigns in other states. We provide one-on-one technical assistance to mentor and advise local staff on best practices and lessons learned from across the country. And we provide policy expertise to ensure that any amendments that are proposed by lawmakers or other groups don't result in regulatory roadblocks or a law that's meaningless once it's passed. We provide guidance to community-based staff for local organizing, and we know when the political climate is ripe. Each state has a seasoned campaign professional who serves as a point of contact with Compassion and Choices. That person can provide local advocates with best practices and lessons learned on how to build a winning campaign, and serve as your partner for advancing efforts locally. We also help you connect to other Compassion and Choices specialists from across the organization. This includes expertise in all facets of campaigning, from gaining media attention to implementing a successful digital and social media strategy, to growing a diverse supporter base. We have a team of policy experts who work with bill sponsors to draft legislation, and policy experts who are available to testify at legislative hearings. And finally, we have a team of lawyers who litigate court cases that help establish and protect the rights of terminally ill Americans. If you're aware of a patient whose rights are being denied or violated under any existing laws, please let us know. We have a tremendous infrastructure at Compassion and Choices, an interactive website that has many points of entry for information about end-of-life care planning to taking action in your state, whether it's a state that has authorized medical aid in dying and we're seeking to defend that law, or you live in a state where medical aid in dying is not yet authorized. We are present on a lot of social media channels. We've got a Twitter channel, a Facebook page, Instagram, and we'll talk about that a little later. But we're all over social media, and follow us there to see what our campaign efforts are, what campaign efforts we have going on across the country. We have a sophisticated database that allows us to manage contacts with supporters, donors, and volunteers in a way that helps us target specific legislative districts. We have a creative and digital strategy service center and a powerful and recognized brand. Let's take a look at what it looks like to authorize a law. It really happens in a number of different stages. As is the case with most legislation, passing medical aid in dying laws take time. In Hawaii, it took 20 years, and in New Jersey, it took 7. And the passing of legislation is only the start. It takes a considerable amount of time to ensure that the law is fully implemented so that patients are able to find doctors who will support them. We've learned a lot over the past 20 years as the new states have increasingly passed and implemented medical aid in dying laws, and we've identified 4 general phases for ensuring everyone in a jurisdiction who is eligible and wants it has the option of medical aid in dying. Today, we'll focus on phase 1 and 2 and what you can do to help. Phase 1, as you see, is grassroots organizing, and phase 2 is our campaign to pass a law. But then you'll see that once the law is passed, we need to implement it, defend it, and then engage in ongoing work to ensure that the law is operating as intended. So in our first phase of capacity building, here are the things that you can do to help build capacity in your state. You can be trained as a Compassion and Choices volunteer. You can help build action teams. The organizer assigned to your state can connect you to a local action team or can help you get one established if one doesn't already exist. Then we can help you host monthly action team meetings. You can help us expand movement support by educating your own social media network and by regularly sending and sharing CNC news, links, and posts. You can help us identify people who are willing to share their story with the public and with lawmakers. You can ask your doctor about medical aid in dying. See how that provider feels about this issue and then connect them to our Doctors for Dignity program so that they can raise their own voices. You can help us build coalitions with other organizations. We can't do this alone. Getting powerful statewide organizations behind you, like the League of Women Voters or the ACLU, is a really important part of our work, and you can help us do that. You can also help us engage in public education efforts, like hosting film screenings and discussions done in person or online, using films like the groundbreaking documentary How to Die in Oregon, or the soon-to-be-released movie Here a While that Kim Callanan mentioned earlier with Anna Camp. That movie is going to come out on June 9th, and we'll have plenty of opportunities for you to help screen it. You can form a book club to read together Barbara Coombsley's book, Finish Strong, Putting Your Priorities First at Life's End. You can lead presentations on end-of-life options, help us pass local resolutions, host a house party, educate lawmakers, and write letters to the editor. So many things you can do. Another thing you can do is share your story. Sharing personal stories can be powerful. Nothing advances our common cause like real stories because they help us interpret and understand the world around us. When we share our stories, we can connect people deeply to our work. And connecting with people moves them to action. If you have a story about medical aid in dying or the need to expand end-of-life options, please let us know. And finally, I want to draw your attention to a fabulous new resource that we've put together. It's our data book, which is jam-packed with useful and interesting information about medical aid in dying over the last 50 combined years that it's been authorized across the states. This is a great resource to share with lawmakers as they formulate new medical aid in dying laws. So we'll stop here and see if we've got some questions. We do have some questions from the audience from our webinar, and we'll move right into that segment now. If I can get Sylvia and Kim back on the line, we've got a number of questions here that we'd like to answer. The first question is for Sylvia, and it comes from one of our supporters in California who said, I heard that medical aid in dying was put on hold because of some legislative challenges. Is that true?
It is not on hold. The California law is in full effect. However, opponents are still fighting to overturn the law. And of course, CNC, we will continue to defend the law until these attacks are defeated.
Thank you, Sylvia. Another question that we got is about Barbara Coombs-Lee's book. The person wanted us to repeat the name and the author of the book. And the book is fantastic. It is by our past President Emeritus, Barbara Coombs-Lee, and it is called Finish Strong, Putting Your Priorities First at Life's End. And I want to emphasize that the book is available on Amazon, and it's also available on Audible, so you can hear Barbara Coombs-Lee actually read the book now. Someone else asked whether we could expand on this book club idea. Do we provide a syllabus? Have we been successful at that? Kim, do you want to talk about some of the efforts around Barbara's book?
Absolutely. Thanks, Corinne. So we do have a whole discussion guide around Finish Strong, as well as a whole toolkit, book club toolkit, if you're interested in hosting a book club. If you go to our website, you'll see in the Plan Your Care section a link to Finish Strong, and that gets you to where you can sign up to become a book club host. Anybody who signs up to be a book club host and provides us with contact information for 8 people that are going to be a part of their book club gets a whole toolkit from us. And if you don't want the official toolkit from us, which includes an autographed copy of the Finish Strong book and the discussion guide, our end-of-life decision guides for the participants, and then some pens and shopping bags. So that's if you want to be an official book club host. But you could also just download a copy of the discussion guide if you'd like to facilitate it on your own. And we've had people using this book club, doing book clubs across the country really successfully. Some people have everybody come, they use it to bring their families together, and they do a book club with their family. Some of them have done the book club over a series of weeks. So the book club reads a chapter each week and does the book club. And others have used it to bring in the younger generation and get them more engaged. It has been very successful, and we would encourage more people to participate in this as an opportunity.
So the next question that we have, I think, is for me, and that is, why isn't medical aid in dying authorized in New York? And believe me, no one wants that to happen more than this native New Yorker. Compassion and Choices has been leading a robust campaign to pass a law in New York. We are hopeful that this legislation will pass soon. Unfortunately, advancing social change legislation like this takes many years, sometimes 20 years in Hawaii, 7 years in New Jersey. We are making terrific headway in New York. We had a really incredible campaign going right up until the time COVID-19 shut us down. The legislature is, while they're still in session, they're focused solely on COVID-19, but we are ready and raring to go when they are back dealing with the business of the state. You can help us get there in New York. If you're interested in getting involved in the New York campaign, please contact us. All right, the next question is wondering if slides will be available to share with my clinical colleagues. And yes, the recording of this webinar and the slides will be available to share, and we're also going to recap this webinar in part 2 of the seminar series on medical aid and dying across the country. You can invite your colleagues to that part 2 of this webinar. We also provide free education on a wide range of topics. Please go to our website, compassionandchoices.org. That's compassion and choices, all one word.org, and click on request a speaker. Or you can always just email us for any reason at info@compassionandchoices.org. Okay, another question is, in a very early slide by Kim Callanan, you showed much higher percentage of support from Catholics than Protestants. This is in contrast to what I understood and expected to see. Are you saying that individual Catholics are not in agreement with the Church's position? Kim, can you answer that?
Absolutely. And yes, your conclusion is exactly right. Individual Catholics are not in agreement with the Church's position. Survey after survey that shows that about 7 out of 10 Catholics support and want this option. And I believe the reason that the Protestant figure is lower, still the majority, but lower, is because evangelical Protestants are so opposed to it that pulls the Protestant figure down.
Okay, thanks, Kim. The next question is for Sylvia. Can physician's assistants or nurses write a prescription for medical aid in dying, or is it just doctors?
So we believe that medical aid in dying should follow the standard prescribing authority in a given state. So currently only physicians are able to prescribe medical aid in dying, but several states, including Hawaii, have introduced legislation to allow advanced practice registered nurses to do so, and others have included physician's assistants.
Great, thanks, Sylvia. So this question is for me, and it is, can I explain the statistics of support from people within the disability community? What is their argument against supporting medical aid in dying? I think what's important to recognize is that what we see is in the limited polling that's been done and in our experience across the country is that it is not individuals living with disabilities that oppose these laws. There are certain leaders within the disability rights community that have been very vocal in their opposition. But we actually don't believe that they represent the majority of people living with disabilities. We share values with the disability rights community, values around autonomy and directing our own care. In fact, this is what people with disabilities have been fighting for decades, is autonomy. There are some arguments against medical aid in dying within the community that focus on the fact that these laws might be used to abuse or coerce people living with disabilities, but we've seen absolutely no evidence of that over a combined 50 years of experience with these laws. In fact, organizations like the Disability Rights Oregon have certified year after year after year that they haven't received a single complaint from someone living with a disability that they've been coerced to use medical aid in dying laws. So these arguments were made over a quarter of a century ago, and none of them have come to pass. Let's see. Let's go to the next question here. Does medical aid in dying apply if a person is dying from COVID-19 and doesn't want to be put on a ventilator, but also doesn't want to suffer a horrible death? Kim, can you answer that question?
Absolutely. So if the person is already terminally ill and has made their way through the process, then obviously if they get COVID-19, they would be able to use the option of medical aid in dying. However, if a person gets COVID-19, they likely, the trajectory is so fast for the disease that the likelihood that they could get through the process, which as we have outlined is overly cumbersome, is very slim. However, there are options for people who have COVID-19 who don't want to be put on a ventilator to be able to realize a more compassionate and dignified end. We put together a COVID-19 toolkit that outlines options where you can try to take advantage of telehealth and hospice, and also an addendum that helps you to figure out whether or not you would want various different treatments, and provides you with all of the statistics. And our national medical director, Dr. David Grube, did a wonderful webinar as a part of our Staying Stronger Together webinar series, where he walks you through the toolkit and what your available options are. So if you are concerned about COVID-19, I would strongly encourage you to listen to the webinar and to read our toolkit, and to take the steps that are necessary in order to ensure that you have the best death possible if you end up in that unfortunate situation.
Kim, we have a number of questions from people about Alzheimer's and the mental capacity requirement. The basic question is, due to the mental capacity requirement, would an Alzheimer's patient without physical issues have the chance to die with dignity? And related to that, is voluntarily stopping eating and drinking the only option, if not? So we're hearing from a number of participants that are sharing with us some heartbreaking stories. What do you say?
Yeah, thank you so much. And there's no question that the Alzheimer and dementia issue is one of the most difficult ones. When you try to advance legislation across the country, it is really essential that the mental capacity piece be a part of the legislation in order to ensure and protect people from abuse or coercion. So that is why it is in the legislation. However, there are ways that people who have dementia or are concerned about that are able to die a dignified death. We have put together on our website a wonderful values and priorities tool that allows you to go through the point at which you would want to forego treatment or stop being force fed should you end up with dementia. And I would really encourage people to go ahead and take a look at that toolkit. It's very powerful. And the reality is that right now, people are living for years, beyond the point at which a natural death could occur, but they simply don't recognize that humans are intervening. So there are options to speed up and accelerate the dying process if you have Alzheimer's that are legal right now, that we would encourage people to take full advantage of. There was also a webinar that we did around this that is on our website as well, that I would encourage you to check out.
Kim, thank you so much for that answer. We'll take a few more questions here. I think, Sylvia, can you answer this question? Can the patient choose the mental health professional who does the evaluation?
They absolutely can. We would, however, just remind folks that in about half the jurisdictions, the provider has to be a psychiatrist or a psychologist, but there's no requirement as to the specific one. In the remaining jurisdictions where it's explicitly authorized, a clinical social worker is also an option.
Okay, thanks, Sylvia. We have a question from, well, I'll read this question. I'm an end-stage cancer patient who lives in a state with medical aid and dying, but my oncologist practices just over the river in a neighboring state. Would she still be able to be one of the doctors who evaluates my request, or does it need to be a doctor licensed in the state of residence? Sylvia, do you think you could answer that one?
Sure thing. In order to protect the patient and the provider, it would be important for the clinician to both practice within the state where it is authorized explicitly, as well as be licensed in that state.
Thanks, Sylvia. And another question, what are the residency requirements in different states? And a number of people asked this question. Yeah.
So the residency requirements vary, and they depend on your state for in general, but in authorized states for medical aid in dying, we would urge you to go to our website, Compassion and Choices, and identify the authorized state you're interested in to collect more information about how you document residency.
Okay, let's see what another question is here. Here's a person who says, I'm interested in hearing about working with hospices, especially in states like New Jersey, which have recently passed the law and don't have established infrastructures of support. What do you think? Kim, do you want to answer that question?
Sure. So in states like New Jersey and other authorized states, we have what's called an access campaign. And part of our access campaign is working to have more hospices adopting supportive policies. So if that's something that you're interested in doing, you can contact your campaign liaison and they can work with you to help do that. We've done so much as having a community come together and organize and put pressure on a local hospice. But a lot of times it's done simply by somebody who wants to use that hospice, letting them know why this option is so important to them. But please do reach out to us if that's something you're interested in.
Two more questions, I think. This person asks, is it possible to have a medical directive sort of arrangement so that I can get assistance in the future under conditions that I lay out? If I understand this correctly, it's somebody who's asking, can I direct care on a really granular level? Can I say what I don't want and want in some kind of a medical directive? Kim, can you answer that?
Sure. So you absolutely can, with a medical directive, direct what care you do or you don't want. And we have, that's part of what our dementia values and priorities tool is so good about doing. And we would encourage you to take a look at that. You cannot, however, direct somebody to euthanize you. So you could direct somebody to forego treatments or to stop force feeding. Things like that are allowable under the laws, but there is not a state in the United States that would allow you to direct and have a third party euthanize you.
In fact, euthanasia is illegal everywhere in the United States. Is that right, Kim?
That is absolutely right.
Okay. All right. So let's go to this last question. Actually, a lot of people are asking this question. What is the current status for New Mexico? And then we've got people saying, what's the current status for Virginia, Minnesota, Pennsylvania? Some of these people say that they've been working to authorize a law for 10 years. What's going on, Kim?
Sure, thank you. So basically, across the country, when COVID-19 hit, most state legislatures either shut down altogether or all of their legislating is around COVID-19 specific issues. So there is almost no place where there is still a chance this legislative session of advancing medical aid in dying legislation. Our efforts at the moment are, with maybe one exception that's confidential, our efforts at the moment are largely focused on preparing for 2021. And so if you live in New Mexico or Minnesota or Pennsylvania or Virginia, I would encourage you to get involved with our activities now. One of the things that the Compassion and Choices Action Network is doing, which is our C4 entity, is they're doing an Ask the Candidate program and making sure that this issue is a part of the campaign dialogue and that that our elected officials and candidates are understanding that it's important, an important option for their constituents. That's a really important way for us to ensure that when 2021 rolls around and state legislatures open back up, that our issue will elevate to the top. Because we not only have to garner enough support within the legislature, but we also have to make our issue bubble up to the top as a priority over all other issues, because resources within legislatures are finite and they can only pass so many bills each and every year. And so they hear from you the more likely that we will be successful advancing legislation in your state. So please get involved and call us, and we can continue the progress.
Kim, I would just add from the New York perspective, if there are states that get back up and running to address the business of the state, that, non-COVID-19 related business, we are ready to go. So, if these bills are picked up by chance in any of these states throughout 2020, we're ready to pick it up where we left off and pass the bills. But I appreciate the questions from people that are eager to move this legislation. Well, that's it for the questions and answers. I appreciate so much all of these questions and your expert answers. I want to thank everyone who participated, and let's talk about some next steps and some resources. Don't miss part 2 of this series. We're going to be doing the second part of this series, Medical Aid in Dying Across the States, focusing on the Access campaign. So we're going to be looking at medical aid in dying where it's been authorized. Just because a state authorizes medical aid in dying, it doesn't mean that an eligible patient can access it. And in this part 2, we're going to hear from someone whose wife struggled to use California's law. We're going to learn about our access campaigns and find out what you can do to help to ensure that all eligible patients can access this compassionate end-of-life option. Part 2 is going to be held on Thursday, May 21st from 5 to 6 p.m. Eastern Time. We have a number of other upcoming webinars in our Staying Stronger Together series. Medical aid in dying, ensuring that terminally ill people can access the law, what I just talked about, which is part 2. Engaging communities of color, another very important thing that we need to do to be successful. This webinar will focus on ensuring all Americans are prepared for the inevitable end of life, which is Tuesday, May 26th from 5 to 6 p.m. Eastern Time. And the next one on deck is opportunities to expand telehealth use amid the COVID-19 pandemic. And that webinar will be held Tuesday, June 2nd from 3 to 4 p.m. Eastern Time. You can learn more and register for each of these webinars at compassionandchoices.org/webinar series. We have an archive on that website of previous webinars that you can see, starting with the one that we held on National Healthcare Decisions Day, which was an incredibly vibrant town hall. And we've also done webinars on how to become a powerful virtual advocate. And we've worked with folks like Diane Rehm. So there's a lot there that you can access on our website. Finally, I want to talk about some resources. We have an incredible end-of-life care planning place on our website where you can look at tools to finish strong. We've got a consultation service that you can access. And we've developed a whole suite of tools around COVID-19 about understanding your options, using telehealth to reduce your risk of contracting the virus, and how to do advanced care planning in this age of COVID-19. You can find all of these resources and more on our website at compassionandchoices.org/end-of-life planning. Please follow us on social media. That's where you will get the most up-to-date information about what we're doing. We're on Twitter, and Kim Callanan, our president and CEO, is active on Twitter. Follow her. Look at all of the exciting things that are happening in this movement. We've also got a national Facebook page. You can just find us by typing in Compassion and Choices. We've got a number of excellent videos on YouTube, and we are on Instagram. So follow us on social media. And finally, Compassion and Choices is funded almost exclusively by donors like you. Thanks to a generous supporter, all gifts that are made to Compassion and Choices by June 30th will be matched 1-to-1. This is a very difficult time for a lot of people. The job numbers have just come in again, and it's, the economy is in a really difficult place. If you are someone who is not in a difficult place, please consider making a donation today. To help make up for the folks who won't be able to donate to us. head on over to our website at compassionandchoices.org/give now or donate. There's a number of different places on our website that you can find to donate and make a generous gift today. I want to thank you all for joining us. I want to thank our presenters. Thank you, Kim. Thank you, Sylvia. This has been really helpful. Thank you for joining us, and we look forward to seeing you on our next webinar.